Hello, my name is Salika Shakir. I'm a medical director at ARUP Laboratories and an assistant professor at the University of Utah Pathology Department. I'm privileged to discuss today a common women's health issue of vaginitis and the major pathogens that are associated with it. Today's topic will cover an introduction to vaginitis, including a basic definition of how it affects women's overall health and the challenges for accurate diagnosis. We will then review the three most common causes of vaginitis, including bacterial vaginosis, candida vulvovaginitis, and Trichomonas vaginalis. We will then discuss the diagnostic options that are from office methods to those that are only performed in clinical laboratory settings, and then wrap up this discussion today looking at recommendations for testing and treatment options. Vaginitis is one of the most common reasons for women visiting the OBGYN, and it is a condition that affects most women at some point in their lives, occurring more so during reproductive years. According to the CDC, bacterial vaginosis alone impacts 21 million women in the United States. So what is vaginitis? It is an inflammation or infection of the vagina. It is associated with a wide variety of symptoms, including itching, burning, irritation, a bad odor, and abnormal vaginal discharge. Someone with vaginitis may have some or all of these symptoms. The challenge of diagnosing vaginitis is that these symptoms may overlap with other conditions as well, such as sexually transmitted infections with chlamydia and gonorrhea. If left undiagnosed and untreated, vaginitis may result in an increased risk of endometritis, which is an infection of the inner uterine lining. It can also cause pelvic inflammatory disease, which is an infection and inflammation of the female genital tract, and can result in serious reproductive morbidity, including infertility and ectopic pregnancies. Having vaginitis can also increase the chance of acquiring sexually transmitted infections like chlamydia, gonorrhea, herpes, and more importantly, it has been associated with transmission and acquisition of HIV. Recent published studies from Barbara Vanderpool's group in Alabama showed that 20% of women testing positive for vaginitis, such as bacterial vaginosis or candida vaginitis, were co-infected with an STI like chlamydia and gonorrhea. And 85% of those individuals that are positive for any STI were also positive for BV or Candida species. And another study showed that there are at least 26% increased risk of acquiring gonorrhea with additional episodes of bacterial vaginosis. With these data in consideration, the 2021 CDC STI treatment guidelines recommend that all women with bacterial vaginosis should be tested for HIV and other STI diseases. Today, we will be discussing the three most common conditions in reproductive women with vaginitis symptoms. About 90% of vaginitis is due to bacterial vaginosis, candida vaginitis, and trichomoniasis. Non-infectious causes, which are not going to be discussed today, including atrophic vaginitis or a foreign body or inflammatory vaginitis, are less common and account for about 5 to 10% of vaginitis cases. Of the three major players, bacterial vaginosis is the most common, with about 50% of cases, followed by candida vaginitis, accounting for approximately 25% of cases, and trichomoniasis in 15% of cases. These can be single infections or mixed infections, and in some individuals, there may be more than one infection present, including other STIs such as chlamydia, gonorrhea, or mycoplasma. This bag of mixed infections with very similar and overlapping symptoms creates a challenge for clinical diagnosis. In one study, at least 37% of women with bacterial vaginosis were also infected with either Trichomonas or Candida. As discussed in the latest slides, Since each condition requires a different treatment regimen, it becomes highly important to diagnose these accurately for optimal patient management. As vaginitis is an inflammatory and infectious condition with an imbalance to the natural vaginal environment, there are certain factors that are associated with increased risk of vaginitis, including but not limited to antibiotic use, any change in hormone levels due to pregnancy or menopause, lack of use of condoms, using spermicides or irritants, and an infection with HSV2 as well, or having new or multiple sexual partners. To reduce the risk of vaginitis, the general recommendations from ACOG include to not use any scented products or douching that may disrupt the normal vaginal environment, but instead have good hygiene, cleansing with clean water, using barrier contraceptives like condoms, and speaking with your healthcare provider about using antibiotics for other infections. So let's now dive into the major players of vaginitis, starting with bacterial vaginosis. Bacterial vaginosis, or commonly known as BV, is one of the most common causes of abnormal vaginal discharge. As mentioned earlier, it is associated with pelvic inflammatory disease and in pregnant women is linked to premature rupture of membranes and low birth weight of infants. BV has also been associated with gynecologic complications, particularly an increased risk of post-operation infections after gynecological procedures, and an increased risk of acquiring other STIs such as chlamydia and gonorrhea. Although BV is not considered an STI, it is more common in sexually active individuals. As BV increases risk of acquiring other STIs, the 2021 CDC treatment guidelines recommend that women that are positive for bacterial vaginosis should also be tested for HIV, chlamydia, and gonorrhea. One thing to keep in mind is that BV is not caused by a single agent, but it is a polymicrobial syndrome. As seen in this image, where multiple different bacterial morphotypes can be seen attached to a vaginal epithelial cell. Bacterial vaginosis can be thought of as a disturbance in the vaginal ecosystem. The current understanding of the pathogenesis of bacterial vaginosis suggests a loss of the normal and highly beneficial lactobacilli flora and overgrowth of commensal anaerobic bacteria, resulting in a state of what is called vaginal dysbiosis. How this may happen is that Gardnerella, which is the key pathogen in bacterial vaginosis and likely sexually transmitted, infects the vaginal epithelium and alters the vaginal environment in such a way that it displaces the protective lactobacilli. The overgrowth of this anaerobic bacteria, which is unfavorable to the normal hydrogen peroxide producing lactobacillus, elevates the vaginal pH and produces metabolites like vaginal sialidase that promotes breakdown of the protective mucus layer on the vaginal epithelium. And this in turn causes increased adherence of BV-associated bacteria such as Etopobium, Prevotella, etc., along the vaginal epithelium, leading to the formation of this polymicrobial BV biofilm. Recent vaginal microbiome studies have shown that BV is not a one-organism syndrome, rather an imbalance involving multiple species of bacteria. This figure of analyzing the vaginal microbiota of about 163 women demonstrated that lactobacillus species, especially Lactobacillus iners and crispatus, were predominant in healthy women and was significantly reduced in women with bacterial vaginosis. Relative to the healthy women, women with BV had significantly higher loads of BV-associated bacteria such as Gardnerella vaginalis, Etopobium vaginae, Megasphaera, Prevotella, all of these detected above the normal threshold and highly predictive of bacterial vaginosis. So a predominant detection of lactobacilli indicates a healthy vaginal environment, as lactobacilli produce lactic acids from glycogen, and this help maintains a low pH or acidic vaginal environment. Lactobacillus also produces hydrogen peroxide, which keeps other bacterial species, especially the ones that cause bacterial vaginosis, in check, preventing their growth and proliferation. Though the complete pathogenic mechanism of BV is not understood, the formation of a biofilm on the vaginal epithelium has been proposed to contribute to bacterial vaginosis. In a study by Switzinski in 2005, in pre- and post-menopausal women, it was shown that lactobacilli are present in the normal vaginal epithelium with some low levels of Gardnerella as well. But in women with bacterial vaginosis, this is replaced by a biofilm of predominantly Gardnerella along the vaginal epithelium. Due to its strong adherence to vaginal epithelial cells and biofilm-forming capacities, it has been suggested that Gardnerella vaginalis initiates the colonization of the vaginal epithelium and serves as a scaffolding to which other species subsequently can attach and form the BV biofilm. One such species that has now been well understood is Etopobium vaginae, which is often found as part of the BV biofilm along with Gardnerella vaginalis. Studies have shown that Etopobium vaginae is rarely considered the sole cause of BV and is often found with Gardnerella vaginalis, thereby making the detection of these two organisms highly predictive of bacterial vaginosis. Therefore, for accurate diagnosis of bacterial vaginosis, a single target assay for Gardnerella is of less utility than those that detect other BV-associated pathogens such as Etopobium in relation to the normal flora of the vaginal microbiome. So far, we've discussed bacterial vaginosis, which is a multiplayer syndrome. Next, let's discuss the second most common cause of vaginitis, which is candida. Commonly referred to as a yeast infection, Candida vaginitis is caused by abnormal overgrowth of one or more Candida species in the vaginal tract. Candida vaginitis can manifest with multiple symptoms such as burning, itching, soreness, and in some instances, vaginal discharge as well. You may make note that many of these symptoms are nonspecific and can be seen with bacterial vaginosis as well. However, in Candida vaginitis, the vaginal discharge is often described as thick, white, curdy, or cottage cheese-like. Candida vaginitis, also known as vulvovaginal candidiasis, is most commonly seen in sexually active women of reproductive age and less common in prepubescent and postmenopausal women, where it is often overdiagnosed, leading to inappropriate treatment. Similar to bacterial vaginosis, Candida vaginitis is not sexually transmitted. However, it is often seen in women with vaginal symptoms and those that are being evaluated for other STIs. Candida species are generally considered normal flora of the vaginal microbiome. However, disruption of the vaginal microbiome can switch the role of Candida from a commensal to a pathogen. Candida albicans is the most prevalent species in the vaginal microbiome and is responsible for about 90% of cases of Candida vaginitis. Other non-albican strains like Candida glabrata are the second most prevalent Candida species, and these are associated with recurrent disease due to azole resistance, which are usually the drug of choice for treating Candida albicans. With regards to its epidemiology, an estimated 75% of women will experience at least one episode of Candida vaginitis in their lifetime, with about 50% individuals having a second episode, and 5% or so will have recurrent Candida vaginitis, which is defined as 3 or more episodes in a year. Candida vaginitis is also one of the most common conditions that are self-diagnosed, for which over-the-counter treatment is available, but misuse and overuse of antifungal therapy has shown to be associated with a high recurrence rate as well. The last pathogen we will discuss today is the motile protozoan Trichomonas vaginalis, and this is one of my favorite organisms. Trich, or TV, is one of the most curable STIs in the United States, with an estimated prevalence very similar to or higher than chlamydia trachomatis. Because it is not a reportable disease, there are no screening recommendations for the general population. And maybe this is the reason why the rates of trich or TB could be higher than the estimated prevalence. In contrast to chlamydia and gonorrhea, which have higher rates in women younger than 25 years of age, the estimated prevalence of Trichomonas vaginalis tends to be uniform across a wide range of ages, with the highest detection in women aged around 45 to 55 years. One such reasons, as noted by Stemmer et al., could be due to T. vaginalis infiltrating subepithelial glands and being detected only during hormonal or antibiotic-induced changes in the vaginal flora. Others have speculated that this could be also due to the fact that since there are no screening guidelines for Trichomonas in the general population, TB is not getting detected or treated and it persists year after year in the patient. The 2022 CDC estimates of sexually transmitted infections report an increasing trend of overall 26 million new infections in 2018, with an increased incidence of 6.9 million from Trichomonas alone. However, one thing to keep in mind is that Trichomonas can be largely asymptomatic, and most individuals don't even realize that they have symptoms, or they have symptoms that may overlap with other sexually transmitted infections. And co-infections with chlamydia, gonorrhea, HIV, HSV, and syphilis can also be pretty common. Trichomonas vaginalis is a well-known sexually transmitted pathogen and is often concurrent with other STIs. When left undetected and untreated, individuals with Trichomonas show an increased time to clear HPV infections and an increased risk of developing cervical lesions. In pregnancy, trich has been associated with adverse outcomes such as low birth weight, preterm birth, and development of pelvic inflammatory disease and endometritis. In addition to these clinical complications, Trichomonas can also increase the risk of acquiring HIV by 2 to 3-fold. Therefore, prompt identification and optimal treatment is a no-brainer for this easy-to-treat pathogen. For this next section, we will focus on the various testing modalities for diagnosing vaginitis and discuss in brief the pros and cons for each method. The first step to a diagnosis requires a visit with the provider where they will take a patient's medical history and document sexual behaviors, perform a clinical examination of the vaginal and vulvar region to look for signs of inflammation, and note whether there is discharge, redness, or any odor. Though the physical examination may provide some clues, it is not the most accurate method for an absolute diagnosis. Studies have shown that simply obtaining a medical history is insufficient for accurate diagnosis of vaginitis and can lead to misdiagnosis, overdiagnosis, and inappropriate treatment. Several tools from traditional and simple clinical point-of-care tests to more advanced molecular methods in the clinical lab are now available for diagnosing vaginitis. CDC guidelines describe the point-of-care test that can be performed as an adjunct to a clinical history and physical examination to support diagnosis of vaginal discharge syndromes. And these tests will include measurement of vaginal pH, a whiff test with addition of potassium hydroxide to the vaginal fluid, and microscopic examination of fresh samples of the discharge to identify presence of clue cells, motile trichomonads, and also budding yeast or pseudohyphae. When such tests are not available, laboratory testing using gram stain with Nugent score, yeast culture, and advanced molecular assays should be used. In clinical practice, wet mount preparation has been the most commonly used method for diagnosing vaginitis. This is usually done by collecting 2 swabs of the posterior fornix or the lateral wall of the vagina. One swab is mixed with saline and examined on a slide for clue cells or trichomonad cells, And another swab is prepared with potassium hydroxide to look at fungal elements. It can also help with the whiff test for production of a fishy odor that could be due to bacterial vaginosis. In a normal wet mount, no yeast, bacteria, trichomonas, or clue cells are found on the slide. White blood cells are not present or usually will be in very low in number. In the case of bacterial vaginosis, clue cells are the single most important predictor of vaginitis, where you can see vaginal epithelial cells covered with many vaginal rods and coccobacilli, creating a granular appearance. In symptomatic women with Trichomonas vaginalis, saline wet mounts can show the mobile trichomonads and large numbers of white blood cells, more than 10 per high power field. And also epithelial cells can be observed. In patients with vaginal candidiasis, a potassium hydroxide prep test can reveal hyphae and budding yeast forms. But this is usually best for Candida albicans and not other species of Candida. The performance of wet mount for the detection of the three major vaginitis causes varies, with bacterial vaginosis having the most sensitivity of higher than 80% with this method. For Trichomonas, the sensitivity can be quite low as 25%, and delays of more than 10 minutes in viewing the wet mount can significantly reduce the chance of visualizing the motile trichomonads. Therefore, prompt examination of the wet mount is highly important. For Candida, the sensitivity is between 40 to 70%. However, lack of yeast cells observed or hyphae does not rule out Candida vaginitis, and presence of Candida does not mean infection. Therefore, other clinical observations such as the appearance of the vaginal discharge and the vagina are also important for the diagnosis. Wet mounts can be performed at the patient's bedside, and we don't really need any advanced equipment. However, many clinicians do not have access to microscopes, and those that do have access require training and CLIA certification. For bacterial vaginosis, microscopy with the Amsel's criteria has been commonly used in the clinic or point-of-care setting. In the Amsel criteria, the presence of 3 of the following 4 criteria provides sufficient evidence for a clinical diagnosis of bacterial vaginosis. And these include a thin, homogeneous, graying, white vaginal discharge, the presence of more than 20% of clue cells per high power field, a vaginal pH of more than 4.5, and a positive whiff test for a fishy amine odor. The image on this slide shows what a clue cell looks like, which is a vaginal epithelial cell surrounded by bacterial clumping that obscures the borders of the epithelial layer. The Amsel criteria method is rapid and done at point of care and can have high specificity. However, compared with the traditional gold standard, which is vaginal fluid Gram-Stain with Nugent scoring, the Amsel criteria has a sensitivity in the range of 37 to 70% and does require microscopy-trained competent staff. In addition, there could be some subjective interpretation of the odor for the whiff test as well. The gold standard method for diagnosing BV is the Gram-staining method with Nugent score. In this method, the vaginal Gram-stain is assessed for the presence of large Gram-positive rods of Lactobacillus species, small Gram-variable rods of Gardnerella, and curved Gram-variable rods of Mobiluncus, another bacterium. A score of 0 to 3 is consistent with normal vaginal flora, 4 to 6 being consistent with an intermediate phase or an altered flora with an emergence of Gardnerella, and a score of 7 to 10 consistent with bacterial vaginosis. Here you can see the change in the Gram-stain morphology from a normal vaginal flora with predominantly Lactobacillus to the intermediate or altered flora stage where you lose the Lactobacilli and see more Gardnerella vaginalis, which then progresses to bacterial vaginosis where you can hardly find any Lactobacilli but tons of other morphotypes. The Nugent score is more specific for diagnosis of BV than the Amsel criteria. However, it is more time-consuming, requires trained and experienced staff, and the results may vary from person to person. In addition, those that fall under the intermediate range are not very well characterized and are always subject to clinical debate on how to handle them and appropriately manage the patient. A point-of-care molecular probe-based assay can also be used for diagnosing vaginitis. This molecular assay uses a DNA hybridization probe that can detect high concentrations of Gardnerella vaginalis and can also detect Trichomonas and candida species in the vaginal sample. The test is rather quick and requires approximately 1 hour to obtain results. The advantage of this method is that rapid results can be obtained targeting all 3 major players of vaginitis. However, it requires a separate specimen for tests such as wet mount analysis and other tests as culture. In addition, it was developed for use in the physician's office as well in the laboratory settings. But clinicians, particularly in lower prevalence populations, may have difficulty interpreting these results. When the direct probe assay is used alone to diagnose bacterial vaginosis, it has been shown to have low sensitivity and specificity when compared with gram stain and Nugent scoring. If, however, this test is used in conjunction with the vaginal pH measurement and presence of amine odor, the test performance does improve with a sensitivity of more than 90%. Another limitation is that the assay detects only Gardnerella vaginalis and not other organisms. And we know that BV is a multi-organism syndrome, so detection of one single organism may not provide us with an accurate or complete picture of vaginitis in this patient. For candida, for patients for whom wet mounts were inconclusive, but symptoms of candida vaginitis are present, a fungal culture for candida species should be considered. Identify candida species by fungal culture in the absence of symptoms or signs is not an indication for treatment, because approximately 10 to 20% of healthy women can harbor candida species in their vagina. In women with complicated vulvovaginal candidiasis, however, fungal cultures are indicated to confirm their diagnosis and to detect non-albicans species. And this is particularly important for identifying Candida glabrata, since this organism only forms blastospores and can be easily missed on microscopy, where you're looking for just yeast cells and pseudohyphae. Culture can be performed using a wide variety of agar-based media, biochemical stains and reactions, and most labs now use semi-automated identification systems or MALDI-TOF for accurate species-level identification. The advantage of a yeast culture is that it is specific and allows for species-level identification, and also provides an isolate for antibiotic susceptibility testing. In addition, it is useful for recurrent vulvovaginal candidiasis. But yeast cultures can take a couple of days to grow positive, and often specialized media, biochemicals, or advanced methods are needed for species-level identification. Molecular diagnostic methods using nucleic acid amplification, or NAATs, are now the new generation of laboratory tools for vaginitis diagnosis. NAAT tests with multiplexing capability allow for multiple detection of targets, so you can detect bacterial vaginosis, candida species, and Trichomonas all in one sample. NAATs are advantageous over traditional methods since they do not require microscopy or other point-of-care procedures. And the same vaginal swab specimen can be used to detect other sexually transmitted infections, and these could be either collected by the clinician or patient self-collected. Overall, NAATs tend to be more objective, as they are able to detect specific bacterial targets, both that are part of the normal flora and that could be those involved with bacterial vaginosis. Newer studies have shown that overall, NAAT testing is useful in targeting Candida species that are associated with azole resistance. For Trichomonas, studies have shown that nucleic acid testing is far superior to wet mount microscopy. And compared to reference methods such as wet mount and Amsel criteria, NAAT tests have been shown to be more sensitive and specific and can detect mixed infections for bacterial vaginosis more accurately. There are multiple nucleic acid amplification tests that are available either as lab-developed tests or FDA-cleared for the simultaneous diagnosis of bacterial vaginosis, Trichomonas, and Candida vaginitis, with excellent sensitivity compared to the gold standard tests. However, these assays are not available point of care, and results usually take a few hours depending on the test platform. Though NAAT assays have been shown to outperform traditional methods, studies showing head-to-head comparisons of available NAAT tests are few, and that can make adoption of these methods challenging. So how do these methods compare? Here is the data from 3 different clinical trials evaluating a molecular diagnostic method for BV compared to the reference standard. Both transcription-mediated amplification and PCR methods have shown to have high sensitivity and specificity and can detect multiple organisms, both the normal lactobacilli flora and the BV-associated bacteria, to provide a better picture of the polymicrobial nature of bacterial vaginosis. On the other hand, the direct probe assay detects only Gardnerella vaginalis, which can be problematic, as Gardnerella can be found in normal vaginal microbiotas in low levels as well. A more direct comparison for BV between NAAT test and probe-based assay performed by the Cleveland Clinic in 2020 for 111 paired samples showed that though the sensitivities were comparable, the NAAT assay detected fewer false positives and demonstrated higher specificity with a higher positive predictive value compared to the probe-based assay. And compared to clinician assessment and gold standard methods, NAATs have been shown to be far superior in detection of co-infections, as outlined by the study by Dr. Schwebke's group, where they showed NAAT assays to detect 3 times more co-infections in the study population compared to the clinician diagnosis for all 3 major players of vaginitis. And finally, for Trichomonas vaginalis, NAAT tests are far more sensitive and accurate for detection compared to probe-based assays or traditional wet mounts. These observations have prompted ACOG and the CDC to recommend NAAT testing for diagnosis of Trichomonas as a first-line method. Finally, we're going to talk about what treatment options are available for vaginitis. As vaginitis is often diagnosed in clinic settings, the current methods available are insufficient for accurate diagnosis, leading to inappropriate treatment or misdiagnosis. Diagnosis based on clinical symptoms and characterization of vaginal discharge are not sufficient and have led to over 60% incorrect diagnosis of bacterial vaginosis and 50% misdiagnosis of Candida vaginitis. In some instances, vaginitis is diagnosed without evidence of testing, and women are treated empirically with antibiotics or antifungals inappropriately. As the major players of vaginitis are very different pathogens, their treatment should also be different. And as you can see, the treatment varies. So it becomes highly important to have accurate diagnosis for the appropriate patient management for all these various causes of infectious vaginitis. So in summary, vaginitis is one of the common leading reasons women visit the OBGYN. The 3 major players, BV, CV, and TB, are one of the most common reasons for vaginitis. Women with vaginitis symptoms can have mild to serious complications, and often overlapping symptoms can make diagnosis challenging. The major player, BV, is hallmarked by dysbiosis of vaginal flora and is the leading cause of vaginitis, followed by Candida vaginitis and Trichomonas. A wide variety of testing is used to diagnose the 3 major players of vaginitis, and this could be done either at the clinic setting or in laboratories. And we've discussed both the pros and cons for each of these methods. And finally, treatment should be tailored for the underlying cause of vaginitis. Therefore, it becomes highly important to accurately diagnose the cause of vaginitis for better patient management. Thank you for your time today, and I wish you all a great lab week.